So good morning, good afternoon, or good evening, depending from where you are joining us tonight. And welcome to our educational webinar today that will discuss the latest hot topic in multiple sclerosis. We are delighted today to host three multiple sclerosis specialists from leading neurology institutions from the UAE and UK to weigh in on the recent advancement in multiple sclerosis, targeting mainly the cause of disabling disease, as well as a newly approved treatment and the different therapeutic strategies. Before introducing our first speaker, let me thank Janssen Neuroscience for supporting this educational activity. Our first hot topic is Epstein-Barr virus as the leading cause of MS, as it was demonstrated by a recent study from Harvard School. These findings and its clinical implication on our MS patient will be presented by Dr. Muna Thakur. Dr. Muna Thakur is a well-experienced neurologist with more than 20 years of experience to her credit in UAE and India. She had her basic MBBS and MD in medicine from Nagpur University, India, and DM and DNB in neurology from Bombay Hospital, Mumbai University, India. Then she has completed her specialty certificate in neurology from the Royal College of Physicians, UK, and is a fellow of American Academy of Neurology. Dr. Muna has worked in Government Hospital Rashid Hospital as a senior specialist for 10 years, and since last 7 years as a consultant and head of the neuroscience department at Al-Zahra Hospital, which is a tertiary care hospital in Dubai. She is the elected board member of Emirates Neurology Society. Her areas of interest include, but are not limited to, multiple sclerosis, headache, stroke, epilepsy, and movement disorders. She is an active researcher and has numerous presentations in local and international conferences. She has published numerous papers in peer-reviewed journals. Thank you, Dr. Muna, for joining us tonight. Go ahead, the floor is yours.
Thank you so much, Maya. Thank you for the kind invitation and the very kind introduction. I will just start sharing my slides. If you can just unshare yours.
Yeah, sure.
It's still saying that I can't share till someone else is sharing. Can you just stop sharing that other slide?
Yeah, Hussam is stopping sharing. Yeah, perfect.
You can see my slides. So, sorry. So today's topic is Epstein-Barr virus as the cause of multiple sclerosis and its clinical implication. So this is a really hot topic, and thank you for giving me this topic, Maya, because we have this latest study which has sort of revolutionized the whole scenario in MS now. And I would be going slowly into the topic. So what causes multiple sclerosis? So we know that multiple sclerosis is a combination of stuff which happens. So it happens to a person who is predisposed genetically, and then there are environmental and infectious triggers which cause an abnormal immunological response, causing it to give a situation called multiple sclerosis. So what are these environmental risk factors for multiple sclerosis? First and the foremost and the very deeply studied is the Epstein-Barr virus, which we will be going into details: vitamin D deficiency, cigarette smoking, obesity, and gender. all these being the environmental risk factors. And then there is a whole gamut of stuff which happens in between these to cause a situation which is called multiple sclerosis. So these environmental risk factors are usually key factors which occur before the age of 15. And new research suggests that risk factors may occur in utero and in neonates, especially in pediatric onset MS. Lower vitamin D during pregnancy or infancy is also associated with increased risk of MS. And research has also suggested that MS is more common when people are born in post-winter months, especially versus post-summer months. And of course, factors that cause MS cause the onset of MS may differ from those that cause progression. Epstein-Barr virus and multiple sclerosis association, which is the association of infectious mononucleosis caused by Epstein-Barr virus, has been studied since many decades now, sometimes from 90s. And we have multiple meta-analysis showing the prevalence of both infectious mononucleosis and MS having a co-localizing and geographical distribution. Now, this has been studied in a lot of studies before, but nothing has been proved until recently. The hygiene hypothesis also actually proves this, of Epstein-Barr virus being one of the triggers for MS. So what is this hygiene hypothesis? The hygiene hypothesis says that during childhood, if there's high level of sanitation and the child is not exposed to common pathogens, then there is an increased risk of aberrant immune response and autoimmune disorders, which can be triggered by viruses like Epstein-Barr virus. So what is this Epstein-Barr virus? So it's a human herpes virus. It is found all over the world. And most people do get infected with EBV at some point in their lives. And this usually spreads through body fluids, especially saliva. And it causes a disease called infectious mononucleosis. But most of the time, it does remain asymptomatic. And in US, approximately 50% of 6 to 8 years old children and 90% of 18 to 19-year-old adults actually exhibit evidence of prior EBV infection. And once EBV infection occurs, what it does, it infects the B cells and the epithelial cells, and then they persist in the B cells in a latent state, which is chronic and can be lifelong. So what happens when you get this infectious mononucleosis? The symptoms could be fatigue, fever, inflamed throat, sore throat, swollen lymph nodes, enlarged spleen, swollen liver, and rash. How do we prevent this? Well, till now, there's no vaccine to prevent Epstein-Barr virus, but you can protect yourself by not kissing, sharing drinks, or personal items like toothbrushes with people who have active Epstein-Barr virus infection. And till now, there is no treatment for Epstein-Barr virus. So what happens when this infection does occur? So there's a primary infection, and then the virus enters the body, and then it remains persistent in the B cells. And when the virus gets incorporated in the B cells, these B cells can be activated to become plasma cells. They can be activated. They can cause activation of the T cells, and then they can be persistent in the B cells as infected cells. And of course, they can cause antibody production as well. So how do we test Epstein-Barr virus? So there are many antigens which can be tested for EBV. The first one is the viral capsid antigen, or the VCA. So the VCA IgM usually appears early in the Epstein-Barr virus infection and usually disappears within 4 to 6 weeks. So this is an evidence of early infection. IgG VCA appears in the acute phase, peaks between 2 to 4 weeks of onset and declines slightly after and then persists for the rest of the person's life. Then there is the early antigen IgG, which appears in the acute phase of the illness, generally falls to an undetectable level after 3 to 6 months. In most people, the detection of antibody to EA is a sign of active infection. However, 20% of healthy adults may have antibodies against EA for life. EBV nuclear antigen or the EBNA antibody is determined by a standard immunofluorescent test and is not seen in the acute phase, but slowly appears 2 to 4 months after a person has got infected. Then the very popular monospot test is there, which is not a very recommended test because it's a very non-specific test. There's a lot of false positive and false negative. And at best, the monospot may indicate a person has a typical case of infectious mononucleosis, but doesn't confirm the presence of EBV infection. So that's how the serologies go. So the IgM against EBV VCA is in the early phase. And then in the acute and in the chronic phase, you have the EBNA IgG. So Epstein-Barr virus is associated with a lot of other diseases. And you can see it's associated with lymphomas, hepatitis, gastric cancers, nasopharyngeal cancers, herpes, Burkitt's lymphoma, inflammatory bowel disease, and of course, multiple sclerosis. Well, we have known about Epstein-Barr virus since the 90s, but this Jan 2022, we had this very landmark study which came in, which was done by Howard, as Dr. Maya mentioned. Longitudinal analysis reveals high prevalence of Epstein-Barr virus associated with multiple sclerosis. And the results were so astounding that there were many editorials on this saying that the study suggests Epstein-Barr virus may cause multiple sclerosis, and prevention of multiple sclerosis may lead to cure for multiple sclerosis. So were the results of these. So what was this study? Let's go a little bit into detail of that. So the causality or hypothesis was that some individuals who developed MS after EBV infection would not have developed MS if they had not been infected with EBV. A longitudinal investigation of multiple sclerosis incidence in a cohort of Epstein-Barr negative individuals, some of whom will be infected with EBV during the follow-up and some will not be. So this was a 20-year-old collaboration study of US military, and in that they had more than 10 million individuals of different races and a diverse population. And the study was done between 1993 and 2013. So active duty members were screened for HIV at the start of military service and then biennially thereafter. And the serum was actually kept, and there were more than 62 million serum samples which were archived. So we had a lot of serum samples serially kept for all these members, and we could study there clinically and serologically as well. So the stored sample were used to determine the EBV status at the time of first sample, and then in relation with the infection of EBV and the MS onset. So we had a whole life history of the MS and EBV of 20 years. So this was a fantastic data. The cases were matched to randomly selected individuals without MS of the same age, sex, race, ethnicity, branch of military service, and date of collection of the blood samples who were in active military service. And there were 801 MS cases which were found during this study, and there were 1,566 controls. Only 1 out of the 801 MS cases with samples available to assess EBV was EBV negative. So 800 were actually positive. So at the baseline, 35 MS cases who later became MS were actually negative for EBV, and 107 controls were negative. All but one of these 35 EBV negative MS cases became infected with EBV during the follow-up, and all seroconverted before the onset of MS. The median onset time of the first EBV positive sample and MS onset was about 5 years, and the range was between 0 to 10 years. And the median time from estimated EBV seroconversion defined as the midpoint between the last seronegative and the first seropositive was about 7.5 years. So high seroconversion rate was seen in individuals who developed MS during the follow-up, which was about 97%. So what was the risk ratio? The EBV seroconversion by the time of the third sample and EBV seropositivity at the time of the first sample was associated with a 32-fold increase in risk of developing MS. So this was higher than anything which we had ever seen before with a very high p-value. Of course, there were behavioral, environmental, and personal characteristics which could correlate with predisposition of both infection and MS. And to study this and whether there were other viruses as well involved, cytomegalovirus was also studied because it was transmitted in the same way as Epstein-Barr virus. And amongst those who were CMV negative as at baseline, seroconversion for CMV occurred at the similar rate in those who later developed MS and those who did not. So to further elucidate the temporal relationship between EBV infection and MS, what they did was they studied the neurofilament light chain, which is a sensitive and a disease, but not a disease-specific biomarker of ongoing neuroaxonal degeneration, and is used, and this was studied using an ultrasensitive single molecule assay. So NFL levels in individuals who were Epstein-Barr negative as at baseline went on to develop MS were similar to those as non-MS, and before and around the time of EBV infection, but increased after EBV infection. So that means EBV infection was causing neuroaxonal degeneration at the time of the infection, and all of these patients later developed into MS. So confounding factors by known factors is virtually ruled out by the strength of the association. To explain a 32-fold increase in MS risk by any co-founder would have to confirm about 60% or more risk of EBV seroconversion. None of the known or suspected risk factors for MS have such a strong correlation. The next most common risk factors is the HLA-DR15 allele, which confers a 3-fold increase in MS risk only, and is not associated with EBV positivity and thus cannot explain the EBV-MS association. Rather, there is an epidemiological and experimental evidence that EBV infection and HLA-DR15 may act actually synergistically causing MS, and the other environmental factors are far too weak to materially confound the EBV-MS association. So EBV seroconversion occurs before the elevation of serum neurofilaments, which is an early marker of preclinical MS, and a long lag time, about 7.5 years between EBV infection and MS onset, strongly suggests that the occurrence of EBV is detectable by elicited immune response is a cause and not a consequence of MS. So we do have a big proof of EBV causing MS. There was another hypothesis called the two-hit hypothesis for MS with EBV. And what it stated that after EBV infection, there's an enhanced blood-brain barrier permeability, which is triggered by the acute primary infection. And what it does is it allows pre-existing polyclonal antibody-producing B cells to enter the central nervous system. And this is actually detected as an MRZ reaction. And this is called the two-hit model, meaning that the Epstein-Barr virus actually causes enhanced blood-brain barrier permeability. And then these B cells, which are already primed B cells, they enter into the central nervous system and cause MS. So how does Epstein-Barr virus affects the B and T lymphocytes? So as we know that healthy B cells perform destructive process of self-antigen, which results in complete degradation and prevention of autoimmunity. However, after an EBV infection, the B cells convert into a productive processors and cause more overt antigen production. And the memory B cells are immortalized by Epstein-Barr virus. And what they do is they coexist and become indetectable by the T cell surveillance. And these become, these remain into the central nervous system for life actually. So Epstein-Barr virus is kept under control by the CD8 cytotoxic T cells, which kill off the EBV infected lymphoblastoid cell lines. But specific cytotoxic CD8s are primed to recognize and eliminate infected cells which present latent proteins of EBV. And these are referred to as latency specific T cells. During MS exacerbation or a relapse, then an expansion of EBV specific T cell population and the latency specific CD8 T cells. But as MS progresses, latency-specific T cells demonstrate exhaustive phenotype and they fail to control the expansion. Hence, there's a vicious cycle of T cell exhaustion, which leads to more B cell production and the virus triggering the whole cycle. So does EBV also affect the MS disease course? So there have been contradictory findings in this case, but certain serological investigations have shown that intermittent EBV reactivation during active disease course may parallel with the exacerbations of RRMS. And EBV reactivation can be used as a marker to predict clinical disease in RRMS patients. How about MRI and EBV? So we have seen in the MRI studies involving the clinically isolated syndrome that enhanced antibody levels of EBV are associated with greater number of contrast enhancing T2 lesions and increased brain atrophy at the 2-year follow-up. And also in postmortem MS white matter tissues, we have found that along with the pro-inflammatory cytokine interferon alpha, there is EBV encoded RNA positivities were detected in active areas as well. EBV is also seen in the PPMS patients in the lymph nodes and the meningeal infiltrations and in the cervical lymph nodes. And you can see it here that these cells of meningeal aggregate also contain EBV virus. So where do we stand with EBV and treatments? So we now know that a lot of our MS treatments, which are already in the market, actually do affect EBV in some way or the other. Interferon beta, a commonly used disease-modifying therapy, we know has potent antiviral activity. Interestingly, EBV and other viruses have evolved molecular mechanisms to evade the antiviral effects of type 1 interferons. But interferons do result in apoptosis of CD27 plus. These are memory B cells and are reservoirs for EBV. So in reducing the CD20 memory B cells has an effect in reducing the Epstein-Barr virus load as well by interferon beta. How about natalizumab? Natalizumab, after 6 months of therapy, has been shown to be positively correlated with anti-EBNA antibody levels, which were downregulated. So natalizumab also has some effect in Epstein-Barr virus regulation. Glatiramer acetate and dimethyl fumarate also have been shown to reduce the CD20 memory B cells reduction, in turn reducing the load of Epstein-Barr virus. But what has actually changed the scenario is the B cell depleting therapies. And we now know that Epstein-Barr virus long-term latency within the memory B cells is there, and elimination of infected B cells may improve the control of EBV infection. And we have rituximab, ocrelizumab, ofatumumab. All of these cause marked depletion of CD20 molecules. However, intrathecal administration of rituximab did not reduce the lymphoid follicles in progressive MS. So a little more work needs to be done in this case, how to reduce the lymphoid follicles in the meninges. Teriflunomide also has a unique mode of action and has been seen to have an antiviral therapy effect as well. So what it does, it inhibits the de novo pyrimidine synthesis pathway and suppresses the proliferation of EBV transformed lymphocytes without affecting cell viability. And teriflunomide therapy has been seen that MS patients with highest decrease in the anti-VCA IgG actually showed less gray matter cortical atrophy. So have there been any specific treatment for EBV itself? So there was one phase 1 study which was done and was published a couple of years ago. So the treatment was called adoptive T cell immunotherapy, which targets Epstein-Barr virus and has been shown in a group of 10 patients with primary and secondary MS. EBV infects B cells of immune and is known risk factors. So what this treatment does, it takes patients' own T cells from the immune system, primes them to recognize and kill the EBV infected B cells. 7 out of 10 showed clinical improvement, including some reduction in disability and improvement in fatigue. So larger studies are still underway for this adoptive T cell immunotherapy against EBV. How about other therapies like the retroviral treatments and EBV? So there was one case report which came a couple of years back, was this case who was a non-HIV lady actually who received heart treatment, and she showed very good response. And the mechanism of treatment was that the nucleoside analogs could have a direct effect on EBV and a double-stranded DNA virus by inhibiting the lytic EBV DNA replication. And she received zidovudine, a component of combivir, which is known to inhibit EBV DNA replication. So this is still in the infancy, and more study and research needs to be done in this. But what would actually help is vaccination. So EBV vaccination could halt the whole domino effect right at the beginning. But unfortunately, till now, we do not have a licensed EBV vaccine. And it is faced with a few challenges because majority of the EBV infected individuals remain asymptomatic. And we need to have MS susceptibility markers to identify who will be the most suitable population. The closest attempt in EBV vaccination was the GP350, which is a surface protein that mediates attachment of the virus to B cells. And this had a phase 2 clinical trial, which was based on the infectious mononucleosis vaccine. And it showed that the vaccinated group was 4.8 times less likely to develop infectious mononucleosis. However, the vaccine did not affect the rate of initial EBV infection. A prospective study followed the university freshmen before and after EBV seroconversion and recorded that the occurrence of occurrence of infectious mononucleosis, and they showed that the GP350 level was inversely correlated with the severity of infectious disease, supporting the protective role. Interestingly, the seroprevalence of EBV declined from the year 2006 to 12, implicating a larger number of EBV naive adolescents and a greater susceptibility for potential infectious mononucleosis in future generation. So we are still in the infancy of EBV vaccination. But as you can see from the slide, that if we stop EBV infection at this stage, we actually prevent the whole cascade of MS formation. So what are the clinical implications? So now we know that most MS patients cases are caused by EBV, and MS can be potentially be prevented by suitable EBV vaccine. And we need to accelerate ongoing research with primary goal of preventing infectious mononucleosis and post-transplantation lymphoproliferative disease. One of the most effective treatment of MS is anti-CD20, which deplete circulatory memory B cells from the primary site. And we do need more therapy to see how we can reduce the meningeal lymphocyte aggregations as well. So vaccine against Epstein-Barr virus could perhaps eventually eradicate MS the same way polio was eradicated. And EBV vaccine wouldn't necessarily help patients who have already developed EBNA1 or glial-CAM cross-reactivity. For those patients, a better option would be to tolerize the immune system so that it no longer responds to glial-CAM. Two promising technologies are here. One, the reverse vaccine using DNA plasmids, and the other is using the RNA technology, which we have used for the Pfizer vaccine against COVID-19. The discovery of how EBV triggers MS could have ramifications for research into other autoimmune diseases such as lupus, rheumatoid arthritis, which like MS are significantly associated with EBV infection in epidemiological studies. And with that, I would thank you for your attention.
Thank you, Dr. Mona, for an excellent presentation highlighting the risk factor for the development of MS and focusing, of course, on the EBV infection as the main or the major risk. So we can take some questions. So the first question, in your opinion, doctor, so what does this Harvard study add to the MS etiology? So we know there has been a lot of study associating EBV infection and mononucleosis with the development of MS. So what does this study add? And does it answer the question that EBV equal infection during childhood equal MS?
So thank you for the question, Maya. Till now we were still not very sure. We knew that it is highly correlated with MS in patients, the prior EBV infection, but we did not have the proof to say so. But now we do have the proof that this is the way forward. And once we know that there is a cause, though it is not the only cause, because we need to have a genetically patient who will get MS in a particular environment, but at least we now know the trigger. If we know the trigger, we will find ways to treat the Epstein-Barr virus. And the best way to treat it would be the vaccination, as I mentioned, so that we do not let it come across. But I think it might not be the only way forward, but as science is progressing, we will now know, because till now we did not know the exact cause. But as of now we do know. We should put all our energies into finding and stopping this infection.
Another question, talking about the risk factor for multiple sclerosis in general. So what do you think, and or can we tell us more about the microbiome and the gut microbiota and as a risk factor for multiple sclerosis?
Yeah, so this gut hypothesis and hygiene theory actually proves that. So we have seen in populations where in the childhood they do get infections at an early age. Their immune system is sort of primed, and they are not naive or sort of not immunized to these infections. So in the later age or in adolescence, if they do get this infection, they have an aberrant immune response, which could lead to autoimmune response and cause multiple sclerosis. So the gut theory is now gaining a lot of momentum, and I think we are still into the research to see how we can prove that as well.
So also as clinician, I'm sure since this data has emerged in social media and on our social media platform, we have received a lot of questions from our MS patients asking what if an EBV vaccination has been developed, for example, now in the upcoming 1 to 2 years, would they benefit from it as they are already diagnosed with MS and they already developed the disease?
Unfortunately, no. So this has to be done. This has to be done before you actually get the trigger, because once you have the disease, we know probably that the Epstein-Barr virus is already inside its B cells and is actually reactivating multiple times. So this has to be done before the first infection.
Yeah, so probably the children of those MS patients could decrease the risk by taking the vaccine, probably.
Yes.
Yeah. And another question from Muhammad. He's asking you, Muhammad Memon, do we have any genetic screening for MS to identify patient at risk of developing the disease?
So at this moment, we don't do the screening test, the HLA, but there are tests which can be done. So there is a concordance rate. So if you have a first degree relative in your family, then you do have around 20-25% increased risk of having MS. So if you have a family history, yes, your incidence, your chance of getting MS is a little higher than a general population.
So thank you, Dr. Mona, for joining us tonight. These were the questions received from the audience. So let us not delay Professor Giovannoni, and let me introduce for you our second speaker. So Professor Giovannoni is the professor of neurology at Bilzer Institute, Barts, and the London School of Medicine and Dentistry, Queen Mary University of London, and the Department of Neurology, Barts Health and NHS Trust. His clinical interests are multiple sclerosis and other inflammatory disorders of the central nervous system. He is particularly interested in clinical issues related to optimizing MS disease-modifying therapies, and his current research is focused on Epstein-Barr virus as a possible cause of MS, defining the multiple sclerosis and phenotype, MS-related neurodegeneration, biomarker discovery and validation, and multiple sclerosis clinical outcome. His team focus on translational research, and therefore he have an active clinical trial program. Professor Giovannoni will discuss the emerging disease-modifying therapy that were recently approved for the treatment of relapsing remitting multiple sclerosis. Again, thank you, Professor Giovannoni, for being with us despite your super busy schedule. You can start with your presentation.
You'll have to stop sharing if you don't mind.
Yes,
okay.
Sure.
You can go ahead and share the screen.
Okay, so I can share my desktop. Yeah, there we are. So you can see my screen, I assume. You can see everything, is that all right?
Yeah, yes, Professor, yes.
Okay. So yeah, actually, I took the brief wrong because you said emerging. So I was thinking about the future in a way that, so I'm going to give you like a helicopter view of where I see the MS field going. And I'm going to focus on how we need to go from where we are now in terms of anti-inflammatories to where we want to be in terms of optimizing the long-term outcome of people with MS. Just to point out, I do have a large number of disclosures, and I sit on various steering committees and have been involved with MS drug development for over 2 decades. So as you know, our current target, well, in my opinion, the previous target is NEDA. How do we make people free of clinical disease activity, not only relapses, but also MRI activity and disease progression. Now, unfortunately, I think this disease progression needs to come out of it because, as I'll show you, it's a difficult one to target with anti-inflammatory therapies only. So I'm actually focusing now on NAIDA, no evident inflammatory disease activity, which I think relapses and MRI activity, and disease progression needs to be a different target. So one of the things that has clearly come about now is this, what I call NIDADI. This is no evident disease activity and disease improvement. And the reason why I say that now is when we actually start to use high efficacy therapies in clinical practice, we see a significant proportion of patients improving. And the drug that made us aware of this first was alemtuzumab, particularly because it's used relatively early in the UK in patients that still have the ability to recover function. And there's no doubt that what dictates recovery of function is being young, having the ability to recover function, being early in the disease course with low disability and less end organ damage. In other words, you don't have too much low lesion load, less brain atrophy, etc. And potentially the mode of action of the therapies. And you can see this is quite remarkable in the KMS1, which is the naive patients, and KMS2 with suboptimal to injectables. You can see, roughly 40% of patients make an improvement, which is confirmed disability improvement. This is much higher than potentially other therapies. And actually, this is also mirrored in the HSCT data. So there's something, in my opinion, specific about these very high efficacy therapies like alemtuzumab, like HSCT, that's different from the others. And what may be happening is you may be triggering repair mechanisms that are driven from the peripheral immune response. And there is some evidence that both HSCT and alemtuzumab trigger growth factors that may drive recovery. So it's not unexpected now for some patients to want, and this is much higher than with other standard anti-inflammatory therapies. So if you want this as part of your treatment strategy, you need to think the top end of the efficacy spectrum. Now, what about add-on remyelination? So just to say to you, there has been a lot of activity going on in the remyelination repair, and I've got a list of 10 plus therapies here. Most of them have turned out to be disappointing. Most recently, the high-dose biotin and opicinumab have been negative, and elezanumab, which I will discuss, the phase 2b results will be reported, I think, at the American Academy. And the next therapy that's going into trial in the UK is metformin in combination with an anticholinergic, clemastine. As you know, there was a lot of excitement about high-dose biotin based on the phase 2 results, but unfortunately, the phase 3 results turned out to be negative. Similarly, opicinumab, so this is anti-LINGO-1. This, as you know, LINGO blocks remyelination, or blocks the OPC2 oligodendrocyte to myelin formation. And there was a hint that there could be a subpopulation of patients from the phase 2 trial, the synergy study, where opicinumab may have worked. This tended to be younger patients with evidence on MRI of the ability to remyelinate. Unfortunately, if you were at ECTRIMS, Peter Calabresi presented the results of the affinity study, and it was unfortunately negative. As you can see on the left here, you can see the placebo versus opicinumab. There is a trend, but as you can see, the wide confidence intervals, it wasn't significant at week 72. So this is a failed remyelination. Now, what's really important is that when you actually look at the different drugs that opicinumab was added onto, you can see there's clearly a much bigger signal, a much wider gap in the people on dimethyl fumarate who had opicinumab added on top. And there may be biology behind this. Okay, there is something very special about the fumarates in terms of how they work. They actually bind to a receptor called the HCA2 receptor, hydroxycarboxylic acid 2 receptor, which is the niacin receptor. And they affect redox signaling in the cell, and they increase this transcription factor called NRF2, which promotes survival or recovery, and it downregulates NF-kappa B, the master transcriptional factor for inflammation. So this particular change that occurs in the cell may be very important for anti-aging, and I'll come back to that, but may also be promoting recovery. And this is one of the reasons why, and interestingly enough, metformin does exactly the same thing. It increases NRF2 transcription. So a lot of studies are going to go forward in remyelination with metformin as the baseline therapy, and maybe dimethyl fumarate in terms of our own disease-modifying treatments should be the platform therapy on which to build recovery or remyelination trials. Just to say to you that elezanumab, this is a drug developed by AbbVie. This is also another inhibitor of remyelination, and if you block it with the monoclonal antibody, you get growth cone collapse, and you get recovery of function. What's interesting about this particular pathway, it's not only about remyelination, it's also about axonal sprouting and synaptogenesis. So this potentially could be one of the first restorative therapies, in other words, allowing axonal sprouting, synaptogenesis, and remyelination. And the animal data, at least in spinal cord injury, is very exciting. So let's hold fingers. I've got a feeling it's not going to be positive because the trial design is flawed. And if you're interested in understanding why I think the trial design is flawed, I'd like you to read this editorial or commentary or review that we published earlier on this year in MSARDS about why we are failing as an MS community in terms of our trial design. I don't think it's the biology. I think we've got the biology right. I think, from an animal model perspective and what we know about the biology, I think drugs like high-dose biotin, drugs like opicinumab, drugs like elezanumab, they're working around the right biology, but I think we're failing because we are not doing the trials right, particularly adding in exercise and rehabilitation. So that's where we are with remyelination. We mustn't give up because we should learn from our mistakes. So I want to pause here and just let you register that we've got quite a few negative remyelination trials and neurorestoration trials. And I'm saying that I don't think it's science that's failing us. I think it's trial design. And if we can learn from our mistakes, maybe we will move the field forward. What about evolving therapeutic targets? So this is just the case I always put up because she illustrates quite a few points. And this is a lady who had very active MS, failed glutaric acetate, then failed alemtuzumab, and then was put on to natalizumab, and actually was very stable. So she was NAIDA, no evident inflammatory disease activity, but she was getting worse on her upper limb function. And you can, I'll put up her scans from 2014, 2019, just to show you how much spinal cord atrophy she's got. So this is a patient who is stable in terms of inflammatory activity, stable on EDSS, but is getting worse when you actually use an Arnold PEC test to monitor her. So when you look more carefully, you find worsening. And she's got clear brain volume or spinal cord volume loss. So she's got what I call smoldering MS. And this term inactive versus active, I think, is wrong, because when these people come to post-mortem, I'm talking about people dying end-stage MS with primary or secondary progressive disease, and they're considered inactive. When you look under the microscope, the majority of these patients, okay, close to 60% will have inflammatory activity in their brains or spinal cord, and almost 80% of lesions are considered to be active. And there's quite a large body of literature showing this. So this term inactive MS, we need to get rid of. We need to think of a different term for it. And this is why I've kind of started using the term smoldering to try and capture the processes that are occurring beneath what we see clinically or on MRI scan. Now, we now know from work done by Shibi Bilicu, who was at Biogen, went to Roche, went back to Biogen, looking at post-hoc analyses of clinical trials, that there's two types of worsening. There's relapse-associated worsening. So when you have an attack and you don't recover, that's relapse-associated. And then the stuff that happens when you are relapse-free or between relapses, what we call PIRA, progression independent of relapse activity. And when you look at the European natalizumab observational program, you can see that despite natalizumab being very effective at suppressing relapses, quite a large number of people go on to get worse. Okay, you can see that almost 40% are worsening over about a 5-year period, and about 2/3 of that worsening has got nothing to do with relapses. We've done the same thing in the ocrelizumab OPERA-1, OPERA-2 cohorts, and again, you can see that the patients that were randomized to interferon, about 30% worsened, of which 80% was PIRA, and with ocrelizumab, it's close to 90% is PIRA. Okay, and the reason why ocrelizumab has got a much higher PIRA rates than because it's much better at suppressing relapses. And the process that drives this is probably end organ damage. And this is just the European Magnum's brain volume loss, showing you that brain volume loss, which is a marker or integrates the damage, occurs at a similar rate across early and late MS. And if you put risk there, we now know from the Italian radiologically isolated syndrome population that it occurs in the risk patients as well. So what I'm telling you, okay, is that this smoldering MS is there from the beginning. It's not something that develops later on. It's there it is the disease. It's from the very beginning. And one of the potential biomarkers for this is the so-called slowly expanding lesion. There are some lesions when you get them in MS, okay, that get smaller and form a little scar and nothing happens. There are other lesions that become hyperdense on T1, you get a black hole. And then when you scan them every year, they start to expand slowly, and they tend to have susceptibility weighted imaging suggesting an iron rim. And that's probably due to macrophages, and these are called the slowly expanding lesion. And there's some different biology around them. It's probably about 1 in 20 lesions are cells. And we now know that these cells, and I'll show you some data, are really poor prognostic sign. And so this is a process that needs to be tackled in MS. So in addition to the slowly expanding lesions with iron, there are other mechanisms that may be driving smoldering MS. Persistent demyelination, which I've referred to already, the hot microglial, potentially the intrathecal B and plasma cell response. We think that the immunoglobulin that is produced within the brain and spinal cord is possibly driving some of these lesions, particularly the cortical lesions, for example. We know there's energy deficits, and we've already alluded to in this symposium already about viruses. Some people think that what's driving smoldering MS is a chronic CNS viral infection, be it EBV or endogenous retroviruses. I don't know. I think the evidence that EBV infects the brain in people with MS is not 100%. It's, there's data to support it, but there's also a lot of data against it, and we haven't got any consensus about EBV working in the periphery or centrally or both in MS. But I do agree with Mona that I'm almost certain EBV causes MS. And I actually think it's not just a hit and run. I think it drives the disease long term. And we may need to target EBV within the central nervous system if we want to manage MS properly. Anyway, so as you can see, there are lots of other targets that go beyond just focusing on the inflammatory events. We really do need to slow down brain volume loss, normalize neurofilament levels, clear the CSF corticoclonal bands, and stop these lesions getting bigger, the slowly expanding lesions. And you say, well, can we get there? And I say, yes. So this is just, this is just the year 9 data from alemtuzumab, just showing you that once you get past the so-called, what you've got to realize is a thing called therapeutic lag. So what's causing the brain volume to the brain to atrophy in this year is from inflammation in the past. Okay, so there is this period when you put somebody on a very effective therapy and switch off inflammation, you're going to still get brain volume loss, and then it starts to flatline, and then it plateaus out or becomes normal, as we all lose brain volume. And as you can see, when you go past year 2 with alemtuzumab, the cohort in general loses brain volume in a range that we consider to be within the normal limits. And this would mirror ourselves clinically. So this population of patients are stable, their disability is improving, and their brains are not shrinking with accelerated shrinking. Okay. And what's really important from this slide is those people that were randomized to interferon during the first 2 years never catch up. Okay, we see the similar thing occurring with ocrelizumab versus interferon. You can see there's a gap that opens up between them in the first 2 years of the study, and then they run parallel after that when the interferon patients are switched. I want to point out, though, that the brain volume loss that occurs with anti-CD20 therapy, ocrelizumab, is nowhere near in the normal range. Okay, so with alemtuzumab, it's around about 0.15 to 0.2. With anti-CD20 therapy, it's running around about 0.35 on average, about almost double. So there is something different between alemtuzumab and ocrelizumab. And we also see a difference in the number of patients that have confirmed disability improvement as well. Okay, so there's something different about the biology of the drugs. HACT, we can see that we lose a lot of brain volume in the first 6 months, and that's probably because the chemotherapy used to ablate the immune system is neurotoxic, and is linked to increased release of neurofilament levels, for example. But then once you get out of the first 6 months, you can see brain volume loss really stabilizes in patients having treated with HACT. And so, I mean, to be honest with you, the brain volume loss from, this is the Ottawa, this is Mark Friedman's cohort in Ottawa. The normalization of brain volume loss in this cohort of patients is really such compelling data in terms of, if you had MS, you'd want your brain volume loss to be normalized. And this is the therapy that does it best, to be honest with you. Neurofilaments, so that's our next therapeutic target. Just to say to you that I think there's been a lot of hype around neurofilaments. We use it in clinical practice in our center, both CSF, and we're beginning to use peripheral blood. And our disease-modifying therapies are pretty effective at reducing neurofilament levels, and the more effective the therapy, the better it is. This is showing you placebo, no change. Interferon brings it down. Natalizumab, which is the most potent, brings it down the most. Okay. Alemtuzumab does the same. We even see it in progressive disease. This is showing you saponamide. So compared to placebo, saponamide reduces it. What is interesting, it's the group in the EXPAND trial, the saponamide secondary progressive trial with relapses that had the biggest treatment effect. So the inflammatory patients compared to those without relapses. But there is still a trend in those without relapses. So this would be called inactive SPMS. There's still some inflammation going on. And this is a problem we have with our current definitions. We define inactive MS as no relapses, no MRI activity. But when you actually interrogate these patients with a drug, there's possibly ongoing microscopic inflammation that responds to saponamide. But clearly, those with relapses prior to going into the trial, the previous 2 years, had a much bigger response. And similarly, those with GAD-enhancing lesions had the biggest response. Okay, and those without GAD-enhancing lesions wasn't significant. But it's also about efficacy. So this particular population was quite advanced, but the most advanced population was the natalizumab secondary progressive or ASCEND trial. And in that trial, there was clearly a positive effect of natalizumab on peripheral blood neurofilament levels compared to placebo. And so I think that, and this population of patients in the natalizumab trial were almost all inactive. They were very advanced, 2/3 of them were EDSS 6, 6.5. Very few had MRI activity in the trial. And so even in this population of patients, so-called inactive, truly secondary progressive patients in inverted commas, there is a anti-inflammatory response. I've already mentioned to you these slowly expanding lesions that we can pick up. Just to say to you that they occur both in relapsing and primary progressive disease, slightly more in primary progressive disease. And when you put people on these treatments, be it in the OPERA, the relapsing, or the oratorio, primary progressive trial with ocrelizumab, you can see there is a slight reduction in volumes over time, okay? And there's a treatment effect. So I'm not saying we can't treat cells. I'm just saying that the impact of these therapies, anti-CD20 therapy, is relatively small and only seen at 120 weeks. This is two factors. It's probably stopping new cells from forming, and it may be having an effect via B cell mechanisms on other cells that are still enlarging. And one theory is that what causes those microglia to be activated and continuing to expand is activation via the Fc receptor, which is via immunoglobulin interactions. So they may be driven by immunoglobulin Fc receptor interactions, which brings in, later on, I'll discuss some therapeutic targets around that particular interaction. Anyway, so I actually think PIRA is the real MS. So, or smoldering MS is the real MS. And the reason why I think that is when we go back and look at natural history studies, we find that inflammatory activity in the form of relapses in MRI is a very poor predictor of long-term outcome. I'm not saying it doesn't predict, I'm saying it's a very poor predictor. So, and it really only early activity predicts long-term outcomes. So what happens in the first 2 to 5 years? Outside that first window, inflammatory activity really doesn't have any contribution to predicting what happens to patients long-term. And when you actually disrupt that link using a therapy, it disappears completely. So this is actually the 15-year follow-up of the intramuscular interferon beta 1A cohort. And during the trial, patients on interferon beta who had activity in the form of relapses or MRI activity were much more likely to end up in the worst quartile of outcome at 15 years. So in other words, if you're on a therapy and you're having relapses or MRI, it's a real poor prognostic sign. But when you look at the placebo arm, it made no difference at all. And if you understand the philosophy of medicine and how using deductive reasoning, this is telling you that this is not the disease and it's not even a surrogate outcome. So I actually think that the inflammation we see in terms of relapses and MRI activity is in response to what the disease is. Something else is going on in the brain and spinal cords of MS, and our immune system may or may not respond to it. And so please don't get lulled into the sense of security that somebody is relapse free or MRI activity free, that you're on top of their disease, because you may not be on top of their disease. Okay. Another clue to this is the other dissociation, and I've just given you one data set here. This is actually the phase 3 ofatumumab. So this is the completely humanized anti-CD20 versus teriflunomide. And despite it being so much more effective than teriflunomide at stopping relapses, okay, there was over 50% reduction in relapses relative to teri, and it almost completely suppressed MRI activity. You know, it was almost much better than teriflunomide in reducing new lesion formation. Its impact on disability progression was relatively modest compared to teri. And when it came to brain volume loss, let's re-baseline at month 12 to get rid of pseudoatrophy, there is no difference between ofatumumab and teriflunomab at the end organ level. Isn't that interesting? Despite ofatumumab being so much more effective at suppressing relapses in MRI activity. So this is telling us there's a disconnect here between what's happening at a visible level on inflammation versus what's happening at the end organ. And we have to start normal. We have to get to the pathology, what's driving this disease in the brain and spinal cord, and think differently about the inflammatory component. Another clue, and this is a really important clue, is when we analyze the data, this publication, this paper will come out in the next few months, I hope. As you know, ocrelizumab is dosed with a constant dose. Everybody gets 600 milligrams every 6 months. So if you are let's give you an example. If you are a 60 kilogram person, okay, you're getting 10 milligrams per kilogram. If you weigh 120 kilograms, you're getting half that dose. You're getting 5 milligrams per kilogram. So built into the trial, there are people of different weights getting different doses based on a per kilogram dose. And you can break them up based on measuring either the drug level or the amount of B-cell depletion that occurs. Okay. And by dividing up into quartiles, and then you say, well, what's the difference between quartile 1, 2, 3, and 4 relative to interferon on MRI activity? And you can see there is no difference. So low dose versus high dose. So this would be low dose versus high dose ocrelizumab is as effective as each other at suppressing GAD-enhancing lesions or new T2 in both the relapsing and primary progressive. So most people interpret this as, oh, we're overdosing them. You don't need to give people big doses. We can get away with giving people doses every 9 months, 12 months, maybe every 2 years. However, and the similar thing was seen with relapses. There was no difference in relapses. However, when you go to disability progression, okay, so this is worsening disability, there's a clear ladder. So there we have at the top here, okay, we have the rebuff interferon arm. And here we have low dose, intermediate dose, high dose. And you can see those that had the highest exposure, the most B-cell depletion, okay, had the biggest impact, and it is highly significant, okay, on disability progression. Okay, these are big studies. This is not small numbers of patients in these studies. We're talking about hundreds of patients, okay? And we saw the same thing compared to placebo in the primary progressive. Now, the ladder is a little bit smaller, but you can see light gray up top there is placebo. And we can see there's 4 doses, and you can see high dose primary ocrelizumab in primary progressive disease was a much more significant. So this is telling us that we had to have more exposure to anti-CD20 therapy than we're getting at the moment. Okay, so what I'm trying to say is that when we look at relapses on MRI activity, there's a ceiling or a floor effect, and we need to go to disability progression to see. Okay, and that's one of the reasons why we've decided as a steering committee to do additional studies. So there are 2 high-dose trials in recruiting right now, one in a relapsing population and one in a primary progressive population, looking at 3 doses of, so we're comparing standard dosing, 600 milligrams with 1200 versus 1800 milligrams. And I would not be surprised, okay, if the high doses are more effective than the low dose on disability progression. They won't be on relapses and MRI activity because we've shown that already, but they will be more effective on disability progression. So please think very carefully about using lower dose anti-CD20 therapy. a lot of people are using low-dose rituximab and being lulled into thinking that you're on top of their meds because this patient is relapsed and MRI activity free. I think it's much more complicated than that. Okay, so we need to wait for this data to come out. And one of the theories is that we need to get more antibody into the central nervous system to clear the brain of B cells and plasma cells. And we know from pathology studies and the brain bank studies that those patients that die and have large numbers of follicles, B cell follicles, they actually have a much more aggressive course and die at a younger age than those without. And so I actually think what we're seeing here is the more we give of acrelizumab in the periphery, more gets into the central nervous system to clear the CNS of B cells. And that's why we wrote this review now 2 years ago about what can we do to scrub the brain clean of plasma cells and B cells. And we're actually doing quite a few trials ourselves. So we've got a cladribine study in more advanced MS with the hypothesis that cladribine will be much more effective at targeting CNS B cells, unlikely to target plasma cells. We're also looking at a proteasome inhibitor. This is a second generation proteasome inhibitor. Bortezomib, as you know, may be very effective as an anti-inflammatory. We're looking at oxazimod. And there's a 5 and possibly a 6 routine tyrosine kinase inhibitor going into clinical trials, which will target CNS plasma cells, but also will inhibit the microglial response as well. So there's lots of activity going on now to try and develop therapies to add on to our existing DMTs to scrub the brain clean of B cells and plasma cells as a target. And we have a clue around cladribine. So this is actually the Polish data. They've been using intravenous cladribine in Poland for decades. And they showed that those that clear the oligoclonal bands after 10 years, in other words, they scrub their CNS clean of bands, are likely to be stable relative to those that don't. And the reason why I put this up is because cladribine is a very effective B cell depleting agent, and it has CNS penetration. So when you dose people with cladribine, you find about a quarter blood levels in the CNS. Add-on neuroprotection. Very quickly, we did a trial showing you that phenytoin versus placebo is able to reduce retinal nerve fiber loss by about 30%. And so there's this theory that we should be adding on neuroprotective drugs like sodium channel blockers. Unfortunately, it's very difficult to get industry interested in sodium channel blockers. The reason being is that they are old news, they're off patent. The new ones don't really have any advantage over the old ones, so people don't want to do the trials. But I have been arguing for some time for the various companies that make disease-modifying therapies to create an online platform where we as an MS community can add on neuroprotective drugs to baseline therapies. And I'll just give you an example here of using ocrelizumab with placebo and then having different arms where we add on different agents to see if we can modify smoldering MS. You may not like ocrelizumab as your platform. At the same time, we should have a platform of DMF, a similar platform running with DMF. And similarly, we should have a similar platform running with fingolimod and other S1P modulators as well, okay, to prove that we can target. Otherwise, I don't know how we're going to do this. And this particular model of adaptive design, adding on therapies on top of existing ones, is what the oncologists do. And they build up the sandwich by having what they call standard of care, and then adding versus placebo, and then adding developing a pyramid or a sandwich. That's the vision, okay? Anyway, we have to go beyond anti-inflammatory and build a sandwich. But in addition to that, we also have a responsibility to look at non-brain MS, non-MS targets, because we now know that there are lots of things that make the brain unhealthy, okay, and that will almost certainly make MS worse. And I'm not going to go time, but there are all these non-MS targets that we need to focus on, okay? And one of them I just put in place is remyelination, CNS remyelination and rejuvenation. So this is really work done by Robin Franklin and his colleagues in Cambridge, showing that old patients, old mice, don't remyelinate or recover function very well. And the reason is their oligodendrocytes are senescent. They go into a sleeping program. And that's biology, because you can rejuvenate these and make them remyelinate by actually starving the animals, putting them on caloric restriction, or giving them metformin. Okay. And how does fasting work? Well, I think fasting works by producing ketones. And one of the ketone bodies you should know about is 3-hydroxybutyric acid. Okay. Which is beta-hydroxybutyrate. And what's interesting about this particular ketone, it binds to that same receptor I mentioned to you earlier. It binds to the HCA2 receptor, hydroxycarboxylic acid 2 receptor, which is the same receptor that fumarates binds to, and niacin binds to. Okay, and this switches that program, upregulates NRF2, and it may actually rejuvenate or make oligodendrocyte precursors susceptible to signals that causes them to make myelin. Okay, and so this may be the mechanism how caloric restriction, how intermittent fasting, and how ketogenic diets work. Okay. Anyway, there's also other data around ketogenesis. So the animal models just showing you that when you use ketogenic diets in EAE, the animals do better. Okay. And there's also some, this is Robin Franklin's data just showing you that by putting animals on diets that mimic fasting, they get ketotic, they also recover function much, much better. So there is biology around dietary manipulation. And we as neurologists know that, though. You know, we've been using ketogenic diets to treat drug-resistant pediatric epilepsy for, decades. And we now know that by making the brain ketotic, it changes the redox potential, changes neuronal excitability, and is actually anti-epileptic, and it's probably neuroprotective as well. So watch this space. A lot of us are very interested in using dietary manipulation for a treatment of MS, or at least as an adjunct to our current therapies. Just to point out, the other factor in that column was comorbidities. So this is just data from Canada showing you the difference between MS patients who have or don't have a vascular comorbidity. So patients who have a vascular comorbidity, and this is either hypertension, hypercholesterolemia, diabetes, smokers, or they have documented vascular disease. If they have any one of those, okay, on average, they get to a walking stick EDSS 6 years earlier than people who don't have that. This gap of 6 years on the Kaplan-Meier in terms of reaching an EDSS 6 endpoint is actually greater than the treatment effect of interferon beta in MS. So we really are missing a trick. You know, we have to really think about what we can do to optimize outcomes. So that's why I'm saying we have to go way beyond inflammation, target other MS processes, but also target the general brain health things. Anyway, so in conclusion then, I hope I've tried to give you a gestalt where I think emerging therapies are coming from, where our treatment targets are going to, and some insights about how our understanding of MS is changing. So MS is not a clinical radiological entity, but a biological disease. Okay, I think the Lublin classification in terms of being inactive, active needs to be changed. We need to update it with new insights. I don't think MS is ever inactive. We need to think differently about our definitions. I think smoldering MS is the real MS, and we need to target that. We have lots of drivers to target in terms of adding on therapies. And please, you know, we need to get away from this blinkered approach that MS is relapses and MRI activity, because it clearly isn't. There's something else going on. And we have to go to the end organ. We really have to think about how do we stop the brain from shrinking and optimizing long-term brain health of patients. Clearly, these insights have major implications for how we do trials. And that's another topic on its own. Okay, and Mona really alluded to this, but I think we need to get really early on in the disease or try and prevent MS. And that's a whole different, that's also an emerging field, this prevention. And I'll stop there and take some questions. Thank you.
Thank you, Professor Giovannoni. So as always, we cannot miss your enriching presentations. So let us take some questions. So I have a question. I have someone asking you about the use of high dose of medication. So you mentioned that we should stick to high doses with anti-CD20, mainly with ocrelizumab. What about other disease-modifying drug? Because sometimes we used to decrease, for example, the dose of fingolimod to every other day whenever we have side effect, or also we tend to use an extended dose of natalizumab to decrease the risk of PML. So do you think that sticking to high dose and high frequency protocol should apply to all DMTs, or this is particular to ocrelizumab?
No, I think these insights are particular to anti-CD20 therapies and ocrelizumab. So it all depends on the biology of the therapy. And we need data that's driven by each individual. I have no idea. I mean, the message I want to get across to you is that you may have a patient who's on fingolimod and they're absolutely stable in terms of no relapses, and the MRI is stable, no new lesions, no GAD-enhancing lesions if you still use GAD for monitoring. But that patient may not be stable. If you monitor the MRIs for brain volume or their cells or whatever, that may be, or you do cognitive tests. So don't just, the question I'm saying to you, don't get lulled into a sense of security that patient is necessarily stable. And I have no idea if reducing the dose of fingolimod makes any difference, or if higher doses make any difference. Unlikely. And so my personal opinion is to use the licensed doses and study that in clinical trials. But I know from experience, fingolimod's like natalizumab, it's like ocrelizumab, it's like all the other therapies. We put people on them and we think they're stable, but they come back 5, 6, 10 years later and they're not stable. They've been getting worse.
Yeah.
So, that's the problem. How do we address that aspect of MS?
Dr. Twaili is asking about metformin. What is its role in MS?
Well, at the moment, we can't prescribe it because it's not licensed for MS, but I think the biology around metformin in terms of rejuvenating oligodendrocyte precursors in animal models is very compelling. And I think that let's wait for the trial. So the UK, Cambridge and Edinburgh are starting a remyelination trial where everybody's going on to metformin. And then on top of that, they get randomized to clemastine versus placebo, and we'll see what it shows. But, if you go outside of the MS space into anti-aging and these so-called biohackers, biohackers are people that hack their own biology or biochemistry to try and promote improved longevity. They are all using metformin off-label. They're buying it over the internet and taking it. I would not recommend that in my patients because metformin, although it's relatively safe, there are potential adverse events. So let's wait for the trial results. But I think we are beginning to think that we need to have drugs like metformin or dimethyl fumarate or diets on which to add on other drugs to promote recovery.
I have two questions about ponesimod. As you know, ponesimod is new on our MENA region market, and we just started having it in some of the country, mainly in the Gulf area. So can you tell us more about the safety, efficacy of ponesimod? You were part of the clinical trials of ponesimod, and also where does it stand in the relapsing remitting MS guidelines?
Yeah, so I mean, the ponesimod, in my personal opinion, is probably will be first in class in terms of the S1P modulators based on its biology and the ease of use. And so it's been given a first line license in the UK, so we can use it as a first line therapy. So I actually see it being used as an intermediate efficacy. So I'm not saying it's at the top end. I'm saying it's intermediate. I think it's going to be used mainly in active relapsing patients as a first-line oral next to Tecfidera, dimethyl fumarate, next to teriflunomide, and it's got advantages over those two drugs in terms of adverse event profile, tolerance, etc. Obviously, the downside of ponesimod is that you can't fall pregnant on the drug. So, there's a group of people who want to start or extend their families that you won't really want to use it because it complicates things. So there's a particular patient there that I don't think would be suitable for ponesimod, but I think it's going to disrupt first-line therapies in this country.
Yeah.
Simply because of its efficacy, ease of use, relatively low monitoring requirements, no need for first dose monitoring, etc. So that's where its niche is. I don't think it's going to be in the UK because of the way it's licensed, a big switch agent, but that's just because of the way the NHS pays for drugs. It's not going to be a switch agent here. Outside of the UK, I can't see why people won't be able to use it as a switch agent if they are intolerant or having adverse events to other oral therapies in the so-called first line space. You know.
And from your personal experience, so how your MS patients are doing on ponesimod, so so besides clinical trial experience, so from your real world experience.
So our real world experience is very limited because we've just got a license and we've got very few patients on it. But let me say to you that when you look at the extension data and I think the S1P modulators, and I'm not going to say ponesimod or any, I think as a class, those who respond very well to respond very well to it. In other words, they're like super responders. And I think that's the message to get across is, when you start a patient on a drug, and you monitor them annually, you rebaseline and you monitor them annually, those that aren't responding, and you get left behind with what I call super responder groups. And we've seen that in the MS space with fingolimod. There's a group of patients that do remarkably well in terms of delaying onset of secondary progressive disease, remaining fully functional. So there's something about using the drugs to find the super responders, okay? But I wouldn't wait too long. You don't want to wait 4 or 5 years to say somebody's failing a drug. You normally get a feel within the first 2 years if they are doing well or not on S1P modulators. And if they're not doing well, you move them on to something else. And if they're doing well, that's great. You leave them on the drug.
So another question, interesting question. What will research or science, in your opinion, achieve faster? Remyelination, cure or prevention, or vaccination?
Oh, no, I mean, to be honest with you, the prevention is an enormous project. It's going to take decades, okay, to show that. And that's going to happen anyway. If we get a vaccine. I think we've got a few patients that are cured. I mean, cure is about how you define it. And I've actually written a review article in MSARDS about how we define an MS cure. And I think some patients may fulfill the criteria already for MS cure. These are the people that have had high efficacy immune reconstitution therapies, mainly HSCT or alemtuzumab very early, and they 10, 15, 20 years down the line, and they've got no evidence of anything. They're fully functional and well. So I'm going to be very provocative when I say I'm not talking about large numbers of patients, I'm talking about a small minority of people may be cured already. Now we've got to understand how that works. What's the mechanism of that? And if it's around EBV biology, then we have to start developing a new class of therapies, for example. Otherwise, we're going to have everything in the middle. Yes, we're modifying this disease by getting rid of relapse-associated worsening, which is a small component, but we're not modifying it enough to get rid of smoldering disease. So we have to, there's lots of work to be done. We haven't got near managing MS, optimizing our management of MS yet.
Yeah, true. A final question about combining different DMTs with different mechanism of action. In your opinion, is it worth it, or from a safety profile, from a safety point of view and efficacy point of view? And do we have current clinical trial investigating the use of a combination of DMTs?
No, well, I mean, we've got the Combi-RX trial, which is interferon GA, made no difference. We've got the Sentinel natalizumab Avanex trial, made no difference. I think you've got to think about synergistic modes of action. You know what I mean? It makes no point in adding two anti-inflammatories that are targeting the same processes. So you may want to use one anti-inflammatory with another. So this is why I made that point about the dimethyl fumarate subgroup in that oportunumab phase 2b trial. They're the ones that seem to respond to oportunumab, and that's where we got to think. And a different biology, one is anti-inflammatory, potentially anti-aging, rejuvenation of oligodendrocytes, and then we're adding on top of that something that blocks inhibition of remyelination. They've got to be synergistic in terms of different modes of action. I don't think putting somebody on, say, natalizumab in combination with fingolimod will make it, that's not going to make any difference, to be honest with you, because the biology, unless you can convince me that fingolimod's getting into the central nervous system, which it does, and stimulating remyelination and doing all those things, I think that's a unknown, that hasn't been answered.
A final question. So with the approval of ponesimod and other first-line oral disease-modifying drug, do interferon have a place in your prescriptions as neurologists?
Yes, I think so. I mean, I've got this website I've started about a year ago called MS Selfie for Patients, and I wrote an article a while back that there is still a place for interferons in pregnancy planning. So we now know it's safe during pregnancy. So de-risking people who are older and want to come off immunosuppression, bridging, okay, around pregnancy, for example. And COVID-19 has shown us that there's a real need for immunomodulatory therapies in terms of vaccine responses. So I do feel it's good to have it. There's still a need. And also people have got previous cancers. So if somebody's on it and they've got a cancer, let's say they're on fingolimod or they're on cladribine or they're on ocrelizumab and they come up with a breast cancer or a melanoma or they get treated, you don't feel like putting those patients back onto chronic immunosuppression. And so there you've got to treat their MS. And maybe I think interferons are appropriate there because they're also anti-oncogenic. They also potentially work against tumors. So I do think there are niche places for interferons. So I don't think they've gone away completely. But I do think though, if you've got a patient who's got active MS, why would you choose an injectable when you've got these new orals around?
Oral.
Yeah. So.
Yeah. Thank you, Professor Giovannoni, again for this presentation. And we'll move to our third speaker. So, ختامها مسك, as we say in Arabic, with Dr. Ahmed Shatila, who will tackle the different therapeutic strategies used to control the disease activity and stopping the progression of MS. Dr. Ahmed Shatila is currently a senior consultant neurologist and the head of the multiple sclerosis clinic at Mafra Hospital, Sheikh Shahbout Medical City, Abu Dhabi, with over 12 years of experience in the field of neurology. He holds an American double board certification in adult neurology and in neurophysiology. Dr. Shatila obtained his BS in biology as well as his medical education from the Medical College of Wayne State University. He conducted a residency in neurology at the same university and continued his fellowship in neurophysiology. Dr. Shatila's interests include inpatient neurology, including but not limited to stroke, IVTPA program development, status epilepticus. He is also interested in helping facilities to develop a neurohospitalist model where the inpatient care can develop independently from the outpatient services. This includes a combination of patient, resident, nursing education, inpatient consulting services, and inpatient neurology services. Dr. Shatila has authored many neurology research papers with emphasis on multiple sclerosis. He is also a member of several regional and international neurology organizations. Dr. Shatila, we are all looking forward to hear your lecture. The floor is yours.
Thank you, Maya, for the very kind introduction. First of all, I'd like to thank the organizers of this meeting for inviting me today to speak. I would like to thank the sponsors, and without further ado, I will start my presentation. Let me share my screen. Okay, there we go. Let me minimize all these cameras and tabs. Can you see it?
Yeah, can we go in full screen mode?
Of course we can. There we go. So
yeah, sure. Yeah, perfect.
So I'm going to talk today about some new treatment strategies for the management of multiple sclerosis. Let me turn on my timer just to keep track because sometimes I talk too much. I'm Ahmed Shatila. I'm a neurology consultant, as Maya had said, at Sheikh Shahbout Medical City. I'd like to also thank Mu'taz Atiyah, who helped me prepare this presentation. Without his help, this presentation probably wouldn't have happened. So thank you, Mu'taz. The majority of this conference or this lecture today is going to be coming out of the MENACTRIM guidelines, the 2019 revised MENACTRIM guidelines for the recommendations and diagnosis and treatments of multiple sclerosis. So let me, again, the camera keeps. So basic introduction, as we know, multiple sclerosis is a chronic demyelinating disease that affects the CNS. We have evolving diagnostic criteria, and with the new oral and the parenteral therapies for MS, most current diagnostic and treatment algorithms either need revision, updating, or complete overhaul. We know that the diagnosis of MS relies on incorporating multiple parameters. There's no one specific test for MS. You've got to use the clinical, the paraclinical findings to prove both dissemination in time as well in space. And then you need to exclude alternative diseases that could possibly cause demyelinating disorders in the brain. So how do we diagnose MS? We know that the diagnosis of MS relies on patient history along with the neurologic examination to determine both DIS and DIT. You also need supportive evidence, which may be provided by extra diagnostic tests, such as the MRIs to identify silent lesions. You need CSF to look for oligoclonal bands or to see if the IgG index is elevated. And once you have that, we know that the identification of patients with CIS or clinically isolated syndrome, the pre-MS stage, they're at a high risk of developing MS, and it's essential to monitor them, especially with the new advent of DMTs, and also to decide if and when you want to start treatment for this subgroup of population. With the new diagnostic criteria of MS, this group keeps getting smaller and smaller, which is good. Now, if we look at the diagnostic criteria, how is it diagnosed? We go back to the McDonald criteria, which initially started in 2001, and it's been revised 3 times since then. The most recent criteria for the McDonald criteria allowed the expansion of the MRI role, improving dissemination in space and time, which also allowed us to diagnose MS even earlier. As I said, the whole CIS subgroup of patients keeps getting smaller because we're using MRIs more and more, and we're able to identify and diagnose people with MS, sometimes based on their first clinical attack or even their first visit. We no longer have to wait 1 month. So what's dissemination in space? We know that dissemination in space is fulfilled when you have greater than 1 T2 lesion in 2 out of 4 regions. What are the regions? It's the spinal cord, cortical, juxtacortical, periventricular, and infratentorial. Interesting enough, when we look at optic neuritis, and it's so common in MS, optic nerve lesion is not part of the dissemination in space criteria. In the revised criteria, we know that symptomatic lesions in the brainstem and the spinal cord are now included. Dissemination in time. How do we prove that? We know that dissemination in time occurs when you have at least a new T2 lesion or a GAD-enhancing lesion on a follow-up MRI. The parallel presence of enhancing and non-enhancing lesions at any point in time. If you have CSF oligoclonal bands, you can now also prove dissemination in time as well. So quickly, now we'll jump to the treatments for MS. So we'll first start off talking about how do you treat an acute relapse. The efficacy of intravenous methylsolumetrol or methylprednisolone has been demonstrated in multiple publications. It works, we know it works, we've been using it for a long time, and we know it. It's a great drug, especially for acute relapses. There have been no significant differences that were shown in the efficacy of oral versus intravenous steroid treatment for treatment of MS. And this was shown in the, I'm going to say the name and I know I'm going to slaughter it. It was the French trial, the COPUSET trial, where they looked at oral methylprednisolone versus IV methylprednisolone. Both of them were just as efficacious. Nonetheless, there was a higher occurrence of adverse events that were shown in the oral group. So what do? Currently, it's recommended in the treatment of acute MS relapses, we should give a 3 to 5 day course of 500 to 1,000 milligrams of daily solumetrol. Plasmapheresis should also be considered for patients who fail to respond to IV methylprednisolone. What about radiologic isolated syndrome? This is a term that we're hearing more and more about, especially since Darren Okuda first brought this to light a couple years ago. RAS is referred to patients with lesions in the brain, but they have no clinical symptomatology. These are people that, get an MRI for a headache or, whatever reason they get an MRI and we see all these demyelinating plaques. And now the question is it MS? Is it pre-MS? What do we do with these people? And we really don't know. We just keep watching them. Currently, there's no evidence to suggest that we should initiate any DMTs before the development of their first demyelinating event. There is some trials going on looking on radiologically isolated syndrome, but as of now, we just got to watch and we wait and see. It is recommended that those patients should be followed closely up for the development for any clinical events without giving them any DMTs, as I mentioned. Clinically isolated syndrome. This is the group of people who have clinically isolated syndrome. Is diagnosed when you have a single episode of any neurologic dysfunction suggestive of MS, which either could be in the spinal cord, brainstem, cerebellum, hemispheres, or optic nerve. CIS patients do not fulfill the revised McDonald criteria. They don't meet they do not fulfill the dissemination in time or disseminate in space. They don't have enhancing lesions. They don't have oligoclonal bands. So, but it is recommended through a thorough review of a diagnosis to rule out any potential mimickers. And if the workup is negative, both clinical and radiological picture is suggestive of MS, people with a high lesion load or severe relapse or any incomplete recovery should be treated. Now, all of the drugs, according to the FDA, have now changed the label. They are approved for the treatment of CIS. And if we look at drugs in particular, certain medications have been studied specifically for CIS and have shown a benefit. Those are the interferons. Cladribine, through the Oracle study, was shown to also be effective in CIS. So yes, we do have the guidelines for the FDA that now has changed in 2019 to include all the medications for CIS, but we do have specific medications that were specifically studied for CIS and did show clinically significant benefit in delaying the first relapse or the relapse to diagnose MS. Relapsing remitting MS. For relapsing remitting MS, right now we have 7 DMTs that are approved for first-line therapy, and this list keeps growing daily or monthly. They have without any restrictions. These are the original ABCR drugs, the Avonex, beta-serons, copaxones, and Rebif. We now have the pegylated interferons, which is a combinant, which is peg interferon, beta-1A. We've got the glatiramer, as I said. You've got teriflunomide, which was also studied in CIS. I forgot to mention that. That was the topic of the TEMSO trial, if I'm not mistaken. And you have DMF. Those are all first-line therapies. We also have 5 other DMTs that are approved for first-line therapy of MS, but there are some restrictions. Ocrelizumab, fingolimod, sapinimod, cladribine, and even alemtuzumab can be used as a first-line therapy for MS, assuming their disease is rapidly evolving, highly aggressive, or they have significant disability. And I have used alemtuzumab for some patients who fulfill those criteria. We'll first start off with interferons. We know that interferon beta modulates cytokine secretions and the activity of inflammatory cells. Glatiramer modulates the Treg cells. Both have shown moderate efficacies in both the reduction of disability progression, as well as the risk of relapse by about 30% based on multi-center trials. In addition, the early treatment with interferon beta 1b was associated with a 47% reduction in the hazard ratio for all-cause mortality in over 20 years. So not only do interferons work, they actually have been shown to decrease mortality when compared to the placebo group. One of the major advantages of interferon and glatiramer acetate, as Dr. Giovannoni was mentioning, these are safe drugs. They don't have a lot of any major side effects. There's the flu-like reactions, like the injection site reactions, but these are drugs that have been out for a long time. They're highly safe, and especially if you have patients that are high risk for any cancers, or you want to bring them, de-escalate them due to advanced age or any fear of prolonged immunosuppressions, and interferons are a great choice. Pegylated interferons is a newly approved subcutaneous interferon, Plegridy, It has a prolonged half-life because it's pegylated, makes the molecule bigger. Thus, it kind of seeps through the body as opposed to giving it in one single dose. In a recent study, that Vantage trial, it reduced the annualized relapse rate by about 36% and the risk of disability progression by 38%, with similar adverse events as the rest of the interferons. So it's an interferon, it lasts longer, but you get the same side effects, and it's just as safe as well. What about fingolimod? Fingolimod is a class of sphingosine-1 phosphate receptor. It modulates and inhibits lymphocyte egress from the lymph nodes, which reduces infiltration and potentially reduces the autoaggressive lymphocytes into the CNS. Fingolimod is the first oral DMT for relapsing remitting MS. And in studies, it reduced the annualized relapse rate by around 55 and 52% compared to placebo, and compared against interferon beta 1A and against placebo respectively. In subgroup of patients with highly active disease, despite the interferon treatment, the year preceding enrollment, fingolimod reduced the risk by 61%, along with the number of lesions and brain volume loss when compared to interferon beta 1A IM. Nonetheless, you do need there are some things you got to keep in mind when you start someone on fingolimod. There are some safety issues. You got to worry about the macular edema, the bradycardia, the herpes zoster reactivation, as well as any prolonged immunosuppressions that you can see sometimes. And speaking of immunosuppressions, we know that there have been 26 cases of PML that have been reported with fingolimod. Water's good. Teriflunomide is the next oral DMT I'm going to talk about. It's the second oral DMT approved by the FDA for relapsing remitting MS. It is a reversible inhibitor of the dihydroorotate dehydrogenase, DHODH. Say that 5 times. This mediates de novo synthesis of pyrimidine, thus by limiting the ability of a cell to reproduce, especially the rapidly proliferating immune cells. You don't have the bad cells reproducing as fast, hence you kind of reduce you reduce their effect on the immune system. When it was compared to placebo, teriflunomide at a dose of 14 milligrams reduced the annualized relapse rate by around 36% and 31%, and the risk of disability progression by 31% and 30% respectively. When compared to interferon beta 1A, teriflunomide had no difference in time to failure. Overall, teriflunomide, it's a safe drug, it's well tolerated. Very mild and rare adverse events are reported, such as some mild leukopenia. You get some mild elevation of the serum liver enzymes, but there's never been a report of liver failure to my knowledge. You do get some hair thinning, but usually it's reversible by 4 months. And it can quickly be cleared out of the body within 11 days by using activated charcoal at 50 grams BID, or cholestyramine 8 grams TID, or you can try 4 grams TID or even BID if they're suffering from too much constipation from the cholestyramine. DMF, dimethyl fumarate. This modifies fumaric acid esters and promotes, cytoprotective and anti-inflammatory activities that are mediated, but partially by this activity on the NRF2 antioxidant response pathways. In the analysis of 2 phase 3 clinical trials, the defined and confirmed trial, DMF 240 milligrams twice a day, showed a noticeable reduction in the annualized relapse rate, around 50%, and a reduction in disability progression by 32% when it was compared to placebo. It is a well-tolerated drug. It's generally safe. There are some adverse events, but they're not severe, but they can be bothersome, such as the diarrhea, the vomiting, and the nausea. We can sometimes reduce this by taking DMF after a big fatty meal. There have been 6 cases of PML that were reported due to prolonged and moderate severe lymphopenia. And that's why it's advised that if anyone has prolonged lymphopenia below 500 for more than 6 months, you should change it. Natalizumab. Natalizumab is a selective adhesion molecule inhibitor. It works on alpha-4 integrin, prevents the diapedesis of lymphocytes from the blood to the brain. And, so it's a self-trafficking molecule inhibitor. This prevents the interactions between the immune cells and the vascular cell adhesion molecules BCAM1 on the endothelial cells. In the phase 3 trial, natalizumab reduced the risk of sustained disability progression by 42% and reduced the risk of relapse by 68% when compared to placebo. Recent studies have shown that increased dosing intervals, EID, of natalizumab every 6 to 8 weeks does not affect the efficacy or the risk of developing PML. Actually reduces the risk of developing PML. Sorry, there was a typo there. Alemtuzumab. Alemtuzumab is a humanized monoclonal antibody. It targets CD52 surface protein. It was developed as CAMPATH back in 2001, short for Cambridge pathology. It's present in high levels on both T and B lymphocytes and to a lesser extent on other immune cells. In 2 phase 3 clinical trials, the CARE-MS1 and CARE-MS2 trials, which included treatment of either naive patients versus alemtuzumab versus other group with interferon beta-1a. Alemtuzumab at a dose of 12 mg/kg was associated with a 55% and a 49% reduction in relapses compared to interferons. Ocrelizumab is also another humanized antibody. It targets CD20. It's given 300 milligrams 2 weeks apart as the first dose, and then 600 milligrams every 6 months. It is approved by the FDA and the EMA for relapsing remitting MS and PPMS. And ocrelizumab has a good safety profile, low incidence of serious infections. I'm going to talk even faster now because for time. There was a slight increase in breast cancer incidence, which was seen in the ORATORIO trial with ocrelizumab. This has been later on shown that it's probably not real. It probably was just due to the fact that the placebo arm was just super healthy. Same thing we saw with the cladribine trial, the CLARITY. But there is still that concern there's still that concern. Cladribine, speaking of cladribine. Cladribine is a nucleoside analog of the deoxynase adenosine, which accumulates within cells. And cladribine inhibits DNA synthesis, repair, and subsequently causes apoptosis. It was approved in Europe for the initial treatment of relapsing remitting MS with high disease activity or patients failing other DMTs. In the US, it's approved for relapsing remitting patients failing other DMTs or active SPMS. Cladribine is given 2 months in the first year, 2 months in the second year, with a total dose of 3.5 mg/kg. In the CLARITY trial and the CLARITY extension, it reduced the annualized relapse rate by 58% and the 6-month confirmed disability by 47% compared to placebo. It has a good safety profile and a low rate of infections and severe infections compared to placebo. There's a slight difference in herpes zoster infections, especially in the subgroup of people who have prolonged severe lymphopenia. It does cause transient lymphopenia. That's how the drug works, but usually recovers by 6 months. And only 5% of those patients develop grade 3 lymphopenia in the extension phase. Sapinamide is a selective sphingosine 1-phosphate receptor antagonist modulator. It inhibits, it's like fingolimod, and inhibits lymphocyte egress to the lymph nodes. This causes a reduction in the infiltration and potentially autoaggressive lymphocytes into CNS. It primarily works on the S1P and has a short half-life. It was approved by the FDA for CIS, active SPMS, and RRMS. Rituximab is a chimeric monoclonal antibody that depletes CD20 B cells. It is approved for multiple rheumatologic disorders, and we do use it for NMO, myasthenia gravis, as well as it was studied for MS in a phase 2 trial, which demonstrated a positive effect for relapsing remitting patients. Several studies conducted in Sweden and other parts of the world did support the safety and efficacy of rituximab compared to other DMTs. One of the studies conducted compared rituximab versus fingolimod, and people that were on natalizumab and switch. After 1.5 years, rituximab was more effective in relapse reduction and GAD-enhancing lesions. It's a safe, well-tolerated medication with a low incidence of infusion reactions. So what's the treatment algorithm? Since there's an increased number of available DMTs, different treatment strategies have been proposed both for the initiation and escalation. Due to the lack of class 1 evidence of competitive data between new agents, in spite of the advances in therapeutic trials in the last two decades, there's a few number of randomized controlled trials that are head-to-head studies. So what's the treatment algorithm? Evidence-based medicine that is derived from clinical trials would give the best therapeutic option for each individual patient. Since there are different mechanisms of actions of new agents, with the absence of comparative data, lateral switching may be an acceptable option for patients with suboptimal response or side effects. For treatment-naive patients, it's vital to start DMTs early to reduce the secondary axonal loss. The choice of therapy should depend on the extent of disease activity, comorbid medical conditions, as well as desire to have children, or the means, or whether the mean of which they would like to take medications. Studies have shown that high disease activity early in the course of the disease is predictive of future disability accumulation. And so how do you dive? The following clinical and radiological features should be taken into consideration when determining if a patient has high disease activity. You got to look at the relapse frequency in the previous year, the severity, whether they recovered, the lesion load, and how many GAD-enhancing lesions they have. What's the recommendations? The following DMTs can be initiated in treatment-naive patients based on class 1 evidence. These are the interferons, glatiramer, UMF, and teriflunomide. With patients with highly active disease, you can give the fingolimod, sapinimod, natalizumab, as Ellis says, ocrelizumab, cladribine, and alemtuzumab, assuming you do proper risk stratification. In patients with rapidly evolving aggressive disease, natalizumab, ocrelizumab, and alemtuzumab are good options to consider. I've already said that. We've spoken about rituximab, so I'm not going to speak about that further. For progressive MS, until recently, we didn't have any FDA-approved treatments for progressive MS. This changed with the oratorial trial, which did show effective efficacy of ocrelizumab in reducing reducing the amount of disability compared to placebo. And as I said, ocrelizumab is relatively safe, very few side effects. And if it fails, you could consider cyclophosphamide, methotrexate, or mycophenolate. So I'm almost done here. What are the treatment algorithms for relapsing remitting MS? This is based on the MENACTRM's guidelines. As you can see, it's kind of the whole summary of what I just spoke about, but in one nice chart, as you can see. Now I'm going to quickly have a couple more slides and then I'll be done, and hopefully in 25 minutes. So this is a nice study showing, this was done in Sweden. It was in JAMA Neurology back in September 2021. This was looking between Sweden and Denmark, and one country uses high efficacy treatments, Sweden, other country tends to use first line, moderate efficacy treatments. And they looked at the registry between the two countries. In these two graphs, you can see the graph on the top left, looked at the proportion of patients who remained progression-free. As you can see, with time goes by, there's a separation of the curves, with the yellow curve being Sweden on top, thus less patients were more relapse-free. When you look at the second graph, top right, the proportion of patients who remained relapse-free. Oh, I'm sorry, one was progression-free, one was relapse-free. Sorry, brain fart. As you can see, Sweden again did better than Denmark, which again goes to show you, you start hard, start early, you tend to have better response. Now this, even though this is not a pharma-sponsored symposium, I did want to include just a couple slides on ponesimod, only because it was not included in any of the guidelines, since this is a new drug. Ponesimod is an oral S1P modulator. This is the Optimum study, which was a double-blind, randomized, active controlled study comparing the efficacy of ponesimod versus teriflunomide. This was a 108-week study. Then there was a 30-day follow-up, and then everyone was switched to ponesimod 20 milligrams for another 240 weeks. So how did it do? When we look at confirmed relapses, there was a significant reduction of around 30.5% versus teriflunomide, and this was statistically significant. When you look at brain volume, there was actually also a significant decrease in brain volume, relative risk of 0.34% versus teriflunomide, which is, it's kind of interesting because in the ofatumumab trial, Kesimpta did not show a significant difference versus teriflunomide, but ponesimod did. And partly that was felt because teriflunomide was so good at reducing brain volume, so to find a drug that did better than that was hard. And ponesimod actually achieved that, which is actually an interesting thing that I thought when I was going through the data. And with that, thank you very much. And I am 1 minute, 13 seconds over. Sorry, Maya.
No worries, doctor. It was a very enriching presentation, straightforward and comprehensive. So we have so far until now 2 questions. So the first question, what about the non-pharmacological treatment for MS? So what do you usually tell your patient to do or to take as non-pharmacological treatment in addition to DMTs?
You know, when we look at MS, we know that you've got the pharmacological therapies and we know that they work, but we also know that the non-pharmacological therapies is the healthy lifestyle, eating healthy, exercising, don't smoke. These are all the things that you can do. Yes, they're not prescriptions, but healthy lifestyle.
Vitamin D.
As well. And vitamin D, yes, thank you for telling me that as well. All of these have been shown to work and are effective. So basically everything our grandmother used to tell us, go out, play in the sun, eat healthy, don't smoke, right?
Yeah, right. And another question, what are the advantage of ponesimod over the available S1P receptors antagonist? And where do you place it in the guideline? Where do you think it will be placed in our Menectrum's guidelines?
You know, that's a great question. I would love to ask you actually that, but I think that ponesimod, the fact that it's first of all, it's been shown to be highly effective. It's shown to be safe. I think ponesimod will definitely be used as a first-line therapy. Now, will it replace the interferons, the DMF, and the teriflunomide patients? I think it probably will to some extent because it's been shown to be more effective. So if you want to start with first-line therapy and you're going to choose, do I give ponesimod versus teriflunomide or the interferons? Why would you give a lesser effective drug when you could give ponesimod and there's no contraindications? So I think as Gavin Giovanni was saying, interferons will always be there, but I think it will be there for a select group of patients who either can't take something else, we want to de-escalate, or they want to get pregnant. And that's, I think, where the interferons will always have a role. But ponesimod, I think, is going to be an interesting addition, and it'll probably be an interesting first-line therapy. Oral.
Okay, so another question for Noor, she's asking, although it's not within the scope of your presentation, about the treatment of acute relapse. So can we treat an acute relapse with dexamethasone instead of Solimedrol if it's not available?
You know, that's a good question. I can't think of any trials that looked at dexamethasone at the top of my head, but I know that some people have used it before. I've never used it, to tell you the truth. We've always had Solumedrol. So I can't.
In Lebanon, with the shortage of medication currently, we are using oral prednisone instead of a high dose of oral prednisone. But as you know, oral usually steroids are associated with higher side effects compared to the intravenous Solimedrol.
Yeah, and I think one of the problems with the oral prednisone is, I know at least in Abu Dhabi, we only have the 50 milligram dose. So to take 1 gram of steroids, that's a lot of pills.
That's too much.
Every day.
Yeah, that's too much. And with Dr. Shatila and his great presentation, our webinar comes to its end. Thank you for our esteemed speaker, Dr. Muna, Prof. Giovanoni, and Dr. Shatila for accepting our invitation. Thank you for our sponsor, Jensen Neuroscience, for supporting this educational activity. The big thank yous goes for you, our loyal audience. I would like to remind you that you will receive your certificate of attendance by email within 1 week of today. Don't forget to join our neuropsychiatry listserv and follow us on social media platform to learn about all our upcoming neurology activities. Stay tuned for our next activity, which will be the first of its kind in the MENA region, and it is scheduled on March 22. All the details will be announced tonight on our social media platform. And until we meet again, stay safe. Have a good night.
Good night, everyone. Thank you, Maya, and everyone for attending.
Thank you. Thank you, Doctor.
Master.